should maybe go ahead and get started. I think I see that all of our speakers are on the line. So let me just go ahead and share the agenda. Say thank you to everybody for being here today. I'm excited to join all of you and to learn some more from our lovely speakers about the transparency and coverage data. So thank you for joining us. I'm Charles Foldyna-Hawley, new family name, same old Charles, and I'm the Director of Projects here at NAHDO. And today I'm excited to introduce your moderator for this session is Mary Jo Condon with Freedman Healthcare. And Mary Jo has been in the space for a very long time. I'll let her say more about her work and introduce herself. But yes, we're excited to have as well Roger Howe, David Muhlestein, Scott Barlow, and Katya Fonkych join us for this conversation. So I'll kind of let them get started here in just a moment. But I wanted to make a couple of quick shameless plugs. Or shameful plugs, whichever. But one of them is to just remind everybody that we are hosting our annual in-person event in Miami, May 6th through the 7th. And this is our, we're calling this our 40th anniversary celebration. It'll be 40 years. We kind of did the 40th annual conference last year. This is actually the 40th launch year. And so we are excited to get together and to celebrate with all of you. The early registration pricing ends on April 6th, just as kind of a quick reminder for everyone. So if you have not registered, you can still get that pricing. And I did hear from Norm, who I don't see on the line, that that the hotel rooms are filling up really quickly, and in fact, maybe are filled up. I'm not entirely sure. So if you haven't made that registration or reservation, maybe give that a shot pretty soon. And then the other thing that I wanted to plug for everybody is just a quick reminder that we are in, and I don't have a slide for this one, but we are in an APCD common data layout maintenance cycle year. And so if any of you have requests or changes that you would like to see made to that document, please let us know. And you can go to the website and fill out the data maintenance request form on the APCD Council site, or feel free to send me an email and let me know as well. But we have until the end of June to kind of hear all of your input on the proposed changes, and then we'll kind of move through the process from there. So without any further ado, let me invite Mary Jo to take it away.
Well, thank you, Charles, and welcome everyone. Welcome to today's webinar on use of transparency and coverage data. As Charles mentioned, I've been around a while, so I'm Vice President at Freedman Healthcare. I also lead our policy and programs department. I was just thinking about it this morning. I've been working with APCD data and known Charles and Norm for close to 15 years now, and so it's always fun to get to dive into new data sources like this transparency and coverage data. These machine-readable files were introduced following the federal transparency and coverage rule back in 2020, and they really started to become widely available around 2022. As you may know, they're published by health insurers and group health plans, and there's also provider transparency and coverage files as well, to disclose negotiated rates and out-of-network payments and other types of pricing data. Our first presenter is going to kick off with more information on what is included in the TiC files, why they were created, etc. And I'm going to introduce those presenters in a moment. But I just want to start by saying how timely I think this webinar is. In the past few months, I've seen so much interesting work developed using TiC files. Our FHC team, for example, recently partnered with the Pennsylvania AFP to look at whether commercial commercial rates for primary care services were higher or lower than Medicare rates for the same services. And we actually found about a third of commercial payment rates were below the Medicare rate. So not a great result for primary care, but very promising for states who are interested in pursuing policy related to primary care investment. I'm going to throw a link to the report in the chat in case you want to give it a read. But again, without further ado, want to introduce our presenters. I'm going to share their names and organizations and ask each of them to share more about their work and their background. So today, to get us started, we have Roger Howe with PayerPrice. He's going to talk a little bit about what is TiC data. Then we'll move to David Muhlestein of Simple Healthcare. He's going to tell us the basics of using TiC data. Scott Barlow over at One Utah Health Collaborative will give us a real-world example of using the Utah APCD data with the TiC data. Very much looking forward to that one. And then Katya Fonkych from the Mass Health Policy Commission will tell us a little bit about what HPC is planning to do with TiC data. So we'll hear from them, and then we'll circle back here and we'll open it up for questions. So really looking forward to these presentations, and let's turn it over to Roger.
Perfect. Thanks, Mary. Just to confirm, can folks hear me all right? Perfect. All right. What I'm going to do is I'm going to share some slides just to give us something to look at that's not me while I talk. Okay. And then, perfect. And can folks see that all right?
We can. We are seeing.
There's two. Perfect. All right. Let's dive in. Good afternoon, everybody. My name is Roger Howe. I'm the co-founder and CEO of PayerPrice. We are a small software company building power tools for price transparency. And I always like to start these off by just showing a quick example of what does this data even look like. Before we dive into the definitions and the legislation, I just wanted to ask a simple question. Did you know? We can see here is just a really quick data sample, where on the left side, I've got the payer, which is United. I've got the tax IDs of a number of nephrology clinics in Georgia. These are all of the renal and nephrology groups that hold contracts with United. I got the NPIs of physicians credentialed underneath this contract. And across the top, I've got CPT codes. There are a number of other dimensions in here as well that are possible, but just wanted to highlight that for every payer, provider, and procedure, you can now see the price, the in-network allowable for every single one of those combinations. Many physicians, many insurers, many TPAs are typically shocked when I show them something like this, because this information used to be very closely held under NDA, but now is public as part of this new transparency and coverage legislation. So what is the price transparency data? I would always encourage everybody to go to the CMS website itself. But I really like the spirit of the legislation, which is that it requires all the health plans to share publicly cost sharing information, in-network rates, in the form of what's called a machine-readable format. That is a format defined by CMS for public use and consumption, so that every stakeholder of healthcare can understand the costs of care. And so what are some of the challenges with working with this data? Just to recover several years of legislation and progress in this legislation over the last couple of years, the law went into effect in 2020. And if you recall, the hospital is required to disclose all that data first. It's been a minute, but 2020 was not the easiest year to start complying with any regulation just due to the COVID chaos that was engulfing all hospitals. Kaiser Family Foundation found that many of these hospital files were difficult to use. And again, during the chaos of COVID, many hospitals did not comply, but CMS indicated it was serious and started fining hospitals for noncompliance. The second half of the law pertaining to the transparency and coverage data required the payers to disclose their data in 2022. And with some of the changes, after the hospital data release, CMS also mandated, again, as I mentioned, that standardized format. The challenge with that format is that it resulted in trillions of data files, trillions of rows of data being released. Several third-party estimates peg this data at several times the size of the entire catalog of Netflix. Just to put this in perspective, roughly how much data is getting put out there? It's about 1.5 petabytes. We estimate that at 3 times bigger than the full Netflix catalog. It's like 25,000 iPhones, 300 million hours of music. And by mandate, this data is actually published on a monthly basis. Okay. So what is the process of actually getting to all of this data? Let's use a really concrete example with United Healthcare. I would encourage all of you as you listen to this call or after to just quickly Google United Healthcare machine-readable file or MRF. The payers are required to disclose all of this data through public portals like this one. When you go to the site, you'll be able to see a list of files like this enumerated by both the employer name or the public name of the United Healthcare plan. When you download these files, they can be absolutely enormous. I will warn you, I melted my laptop the first time I attempted this. But you can download any of these files. Here's one of United's standard PPO files. You'll see that compressed, it's about 11 gigabytes. Uncompressed, it's about 280 gigabytes. And remember, there are tens of thousands of these files. It'll open in, again, that standard, what's called the JSON format. That was what was required by CMS. And if I zoom in a little bit, we can see some of the contents of this file. Reporting entity, United, we can see some NPIs and tax IDs. But as I'm sure many of you on this call could appreciate, it's going to be extremely difficult to put together that beautiful summary table or analyzable data using these JSON formats that CMS have mandated. So while the transparency data is clean and our business certainly finds it easy to work with, as mandated, the data could be very large, complicated, and messy to work with. And so the process of ingesting all this data, again, is to connect to all of the health insurers by law that are required to make their data available to a portal. It is to download all of those machine-readable files and convert them into what PayerPrice calls human-readable formats. So that might be Excel or visualizations, etc. And you'll need to do this over several thousand terabytes a month. I think once you've completed this process, we find the data incredibly workable and manageable to use. But we've, by our own estimates, seen pricing for almost all major commercial insurers. Some of the smaller plans, of course, are missing. Tens of thousands of plans exist across all 50 states, 3.5 million NPIs present in the database, all CPT, HCPCS, MSDRG, APR-DRG codes. Every covered service and procedure must be present in the data. At a really high level at PayerPrice, we call this the 4 Ps of price transparency. Just to simplify things, you can remember the data set has 4 key columns. So the 4 Ps correspond to the payer, the provider, and the procedure. And for all 3 of those columns in a big Excel file, the missing column enabled by this legislation is the price, okay? That's the 4 Ps of price transparency. For every payer, provider, and procedure, this data allows you to see the price. And again, let's just take another look at how this manifests in a data sample. Super easy to bring together millions of rows in seconds through tools like the ones we have or from others on this call. And what you can see here is those 4 Ps in action. We've got the tax ID name, which is the provider here. We've got the payer, which is United. And we've got the price, which is, the procedures across the top, which are these ER codes. And in each cell of this pivot table, we've got the price. So for all United emergency medicine physicians, we can see all the 5 levels of the ED, all the prices for those for each group and each payer. Okay. And I would encourage everybody, don't do all this heavy lifting yourself, to generate some of these analytics, these tables, or even to programmatically access those. There are a suite of tools and services that exist, and I would encourage everybody to check all of those out. A little bit of a shameful plug. Certainly, We've done the heavy lifting so that others on this call don't have to, and our power tools deserve to be leveraged by power users. And that's it as a brief introduction to what is the transparency and coverage payer data, what it looks like, and how you get it.
Great. Thank you so much, Roger. We're going to hold off on questions until we've heard all 4 of the presentations. So next, I'd like to turn to David Muhlestein of Simple Healthcare to tell us more about the basics of using TiC data.
Thank you. It is great to be with everybody today and to talk a little bit about the data. So I am David Muhlestein. My background is health services research. And so I have spent my career trying to make sense of complicated data sets. I've done a lot with claims data and with other things, and I've always been interested in pricing and the lack of information. One of the first papers that I ever wrote during my doctoral program was about the lack of information on any pricing that was available. We scoured hundreds of websites from hospitals, and we found one price for one service mentioned in all of that. Now we fast forward a decade and a half later, and we now have access, as Roger mentioned, to all prices for all payers, for all providers. And it really changes the dynamic with how you think about healthcare and think about data and pricing. So when you're working with this, there are a few things that you need to keep in mind. And I'm going to talk about a few of the challenges that you have to just address. And then I'm also going to talk about some of the use cases of this and how you can apply the data to answer questions that actually matter. So the first one is a concept that is known as a ghost rate. So a ghost rate is when you have a negotiated price for a service for a provider who does not perform that service. So think of this as like a psychiatrist doing a heart transplant. If you were to, no psychiatrists are ever going to do heart transplants. And so if you include those in your analysis, either in terms of benchmarking or trying to do identify providers that might do a service, you're going to be very far off. Now, one of the big challenges is that the payers, the insurers, are required to release data for every contract that's in place. And oftentimes they negotiate with a very broad fee schedule. And so when somebody's negotiating, you might be a primary care practice, and you go in and look and you say, I'm going to focus on the 20 billing codes that I typically do. But your fee schedule might have 1,000 billing codes on that. And what that leads to is a very high prevalence of ghost rates. Last year, we published an article assessing this, and we found that when you go down to the NPI level and you look at that provider to billing code pair, that 95% of all of the data in these TiC files are ghost rates. And so this is not just something you need to worry about on the margins. It's actually a fundamental challenge with the data. There's new proposed regulations that are out right now where CMS and our HHS is going to try to limit how much of these ghost rates are shared to both reduce the size of the data and also make it more actionable. But for now, this is a major challenge. You have to start by removing the ghost rates from any analysis that you have. A second challenge just to be aware of is completeness. As Roger mentioned, most of the health insurers are releasing the data. Not all of them are, but all of the nationals and all of the major ones are releasing data. However, doesn't mean that the data that they're releasing is complete. What I'm going to do is switch to this slide that looks at the completeness of this. And what we looked at is 3 different specialties for physician data for United, Aetna, and Cigna, and then for inpatient and outpatient care. And what we said is, what codes would we expect somebody to be releasing? So if you're a hospital, for example, you'd be releasing a bunch of DRG rates, and you'd have that. If you're a family practice doctor, you're going to have the 9921 codes for evaluation and management type visits. What we found is for the median practice, for each of the different insurers, what percent of the data that we would expect to see was actually released in these massive files. And so if you look at the very top one with cardiology with Aetna, 73.4% of the expected data was in there, or the average, I should say, for the average practice. And that means that you'd say that's pretty good. You're going to see a lot of the data that you would expect to see, and sometimes there's valid reasons why it would not be there. We go and look at United, we see that for cardiology, family practice, and orthopedic surgery for the physicians, over 95% of the data was there. That means that pretty much every billing code that you would expect to see for these practices was there. The problem, though, is that the data is inconsistent. So let's start with the low one. For United Healthcare, for their national PPO network, for their hospital data, only 8% of the data that we would expect to see there was actually there. And that is problematic, particularly when you're using this data to try to evaluate the differences with hospital costs. If the data is missing, you can't work with it. And so it doesn't mean that that's impossible, but when the data is incomplete, it certainly makes it more challenging to use the data in an effective way. So while you've got these massive files that are hundreds of gigabytes, it doesn't mean they're necessarily always complete. Unlike the hospital side, where CMS has issued some penalties, no insurers have been fined yet for failure to comply with this legislation, with its regulation, I should say. And hopefully that will change in the future, and we'll see some changes and improvements with the quality of the data. The next thing I'm going to do is talk through some examples of how you can use price transparency data and how it can be used for learning things about a market. So the first one is just looking at variation that's there. So this is looking for hospitals in New York City for what is the cost for a knee replacement. So this is DRG 470, and this is the hospital component of this. So it doesn't include the surgeon's fee or the anesthesia fee. It's just the hospital side of it. And you can look that if you are using Aetna, there is a huge spread. If you go to Bellevue Hospital versus New York Presbyterian, it's a 2x difference in price. From a cost management perspective, if you're an employer or somebody who has to pay for the price of healthcare, incentivizing and creating tools to help people understand the variations in quality and cost can go a very long way. You can save a lot of money pretty quickly if you can just move a few knee replacements from New York Presbyterian to Bellevue or to Langone because of the difference in pricing. But I do want to compare to other sources as well, because price transparency is coming from multiple sources as well that people have. This is looking from the hospital transparency file. So same thing, and this is from New York Presbyterian. So we saw on the last one that they were the most expensive for Aetna. This is their all-in cost. So this includes both the hospital component as well as the surgery and anesthesia costs is in there. Aetna is the cheapest of all of these health plans, $81,000, so relatively a bargain. But then you look up at Anthem, that's well over $100,000. And so there can be huge variations, both within a single network, but also between the networks that are there. So for employers, being able to choose lower cost networks helps them lower their cost of care. So even if people still go to relatively higher cost providers within that network, all of the costs are relatively lower, and so there's a big opportunity for saving money. And this next slide I'll show you is to show that price discrepancies are not limited just to the commercial sector. This is looking at Medicare. So most people think that Medicare pays relatively consistently, and they do, but it turns out there's a lot of adjustments that go out for different hospitals. So for example, teaching hospitals get a graduate medical education bonus payment that's there. And then you have hospitals like Bellevue that get a very large uncompensated care patient. And what's fascinating is that it's actually cheaper to have a commercially paid for knee replacement done at Bellevue Hospital, paid for by Aetna, than by Medicare because of the increased payment that comes from the uncompensated care. So there is a lot of price variation across the board. It's also in Medicaid. It's also, so Medicare, Medicaid, and commercial are all seeing it, though different levels that are in there. Now, what can you do with the data for the analysis side? And this is where I put on my researcher hat and think about where there's really cool opportunities to understand what's there. One of the first things that I looked at was market competition. And the question is for hospital systems that have an increased market share, how much more do they get paid? And what we found is that for every 1% increase in market share, it was about $100 more that they would charge. And so if you were a hospital system that had 15% market share relative to one that had 5% market share, you would expect that you would get on average $1,000 more for every single hospital admission. So there's a big opportunity to use this data for academic type research. Obviously, people use APCDs for this, but this is just one more tool that people can use and resource to go and look at some of those numbers and understand how they impact things. The next analysis is saying, well, what about for negotiations? So this is a very common tool that people use both from the provider side and from the payer side when they say, what's market and what should we pay people? You can use this to understand what is the relative payments that people are getting within markets. And so this is an example where we took a primary care practice and some common billing codes and said, what are they getting paid by a variety of different insurers relative to the median rate within that market? And so if you look at this for this, I think this is a vaccination, they're getting 110% of the median rate for Aetna. Down here, they're getting 71% of the median rate for Cigna. This is a way that you can really quickly understand whether or not people are getting paid market. The last analysis that I'll get to is letting you show aggregate what costs are going to. This is from an employer. So the employer, we looked at all of their claims data and we said, what percentile were they paying for each of their services? And so, they've got millions of dollars of medical expenses over the course of a year. And for every code, for every billing code, there is a distribution of, or a range of prices that you could have. There's the cheapest providers, and then there's more expensive providers that are there. And where are people going for care? What this allows you to see is, are people going randomly, or are they going to providers that tend to be more in the median or at different extremes for the cost of care? And this is useful for two things. One, it helps people understand from an employer perspective, is there a problem where their beneficiaries are going to high-cost providers? And if so, how do you create tools to help them go to lower-priced locations of service? And the second is when you overlay this with multiple different plans within that market, it allows you to identify which networks would be cheaper for you, given the codes or given the procedures and care that your population is actually using. Which network should you choose that will optimize your healthcare dollars spent? So these are just a few of the examples and some of the pitfalls that people have to address with when they're using this data. And with that, I will pass it back to our moderator.
Excellent. Thank you so much, David. Interested in talking more about ghost rates later. They are definitely an issue. All right, let's turn it over to Scott from One Utah Health Collaborative.
Thank you, everyone. Can you hear me okay?
We hear you great, Scott.
Great. Well, thank you, and appreciate the opportunity to address the group today and share what we're doing. So briefly, I'm Scott Barlow. I'm the Executive Director of the One Utah Health Collaborative. I've been in that position since September. Prior to that, for 25 years, I was the Chief Executive Officer of a large multi-specialty independent medical group throughout the state of Utah, and have been on the delivery side of this perspective. And my group, as most groups in the country are through the CMS pressures, have been taking risks now more and more for care delivery as CMS pushes that out, as well as commercial insurances. So my group had become, over the last 10 years, very sensitive to referral patterns and costs of care and what we could do to really find the most effective ways to take care of patients. And this data is quite important in that regard. So in terms of our organization, the One Utah Health Collaborative was started in 2022 by our governor, Spencer Cox. And through the bully pulpit, he brought together all of the health systems across the state of Utah to be a part of this initiative through a little bit of pressure for sure, as well as a willingness, I think, of all the healthcare community trying to find a better way to take care of patients. The collaborative includes all the major health systems that throughout the state of Utah, payers, hospital systems, medical groups, home health, government officials, Department of Health, things of that nature. So really cross-sector of our entire industry. And again, his goals were three charges: address the cost of healthcare, improve the health outcomes, and increase trust in healthcare in terms of the public sense of the value of the industry and what it can do for people. So that's the genesis of the organization, and we have all the payers. The state provided some funding. It's a private nonprofit. The state provided some seed money, as well as some of the healthcare systems committed resources as well. We really have three specific agenda items. One, just to align the community. And, and I learned as a deliverer of care that had fiscal responsibility for outcomes, that really it's very hard to do this without having the entire system moving. Parts of the system you can fix and harm other parts of it. So our job is to align the community across all sectors, help identify opportunities, basically pull back the curtains and show light, and to make the opaque transparent, and then try to accelerate innovation through the collective efforts of all those parties involved. So in terms of our organization this year, we have really 4 major initiatives, again, that are all interwoven in some respects as to how they work. We're really working hard on improving the data interoperability of just the movement of healthcare data overall. This is clinical data, transactional data, all elements, and try to continue to break down barriers of data moving, as well as trying to push pressures for platforming data in ways that it can be more open source and available for innovation and extraction. Health outcomes continues to be a big part of what we're working on, and have done some great work there, and are continuing to hit some key areas there. Affordability, as we have a goal as a state to reduce inappropriate emergency room use by 10%, and have very active targets and initiatives to facilitate that. And then our major one in relation to this meeting today is transparency, trying to use data now to start provisioning transactional costs to provide insight to the buyers, usually an employer in most instances, or a state agency in behalf of a Medicaid program. But really the employers, but also the patients, where we can start making fiscal understanding a part of that, as well as looking at networks and things of that nature. So in relation to this data, we've got a very active transparency initiative. We do have access to our APCD files of our state, although we've had limited ways in which we can use that because of the politics of that data being used to maybe perhaps unveil information that some health systems may be uncomfortable with. But we do have full access to that. And with the TiC data now as a public domain, it really has removed a lot of the political barriers now, starting to really start to analyze, provision, and help facilitate that insight in order to help people make educated decisions about healthcare consumption. So we are in the process, and we're waiting for the next file load in April, as we launch multiple work groups across our state related to this, of using the TiC data. And our intent is to stand up the data digestion, normalization, provisioning of the data to enable use for any consumer of any plan in our state in terms of decisions of what they need to make related to healthcare, whether that consumer be, again, a buyer of a health plan, or maybe a broker to help create network structures or benefit design, and also the patients to be able to have information relative to care needs that they have to be available. So our goals are by the end of July to have loaded that April file, done some cross-testing with our APCD file to clean up the files. We already done some work there, but we also, because we have the payers at the table with us, we have access to the payers data sets as well as other elements of validation, verification, and use of that data set. So our goal is to complete those exercises by July to have what we feel very confident is a good reflection of transactional costs and opportunities. And what will enable us to do is, when we have some of these gaps in TiC data, and we've seen some of those as well that David's pointed out, to be able to use our APCD data or perhaps payer data to supplement it to make it a more comprehensive, valid data set overall. Our goal is to get reporting tools developed. We've already been working on that. We've tapped into our Masters of Health Administration programs at some of our universities for capstone projects, things like that, and have already been working on report design, structures, methodologies, presentation tools. Again, trying to create something that, once it's digested and available, is actually user-friendly to the respective constituency group, to try to really make sure that the tools are going to be actionable and usable by individuals. So our hope is that April and June continue to work on that reporting queue, with a goal that we want to roll out our first data release to our stakeholder forum members. We really want our industry sectors to have a chance to look at this and see it. We are also cohorting people in geographical cohorts as part of our reporting model, that when an individual is looking at a price opportunity, as David pointed out, we literally have geographic cohorts of like parties that are more representative of the shopping range of what a consumer would likely be using as it relates to network access and service access. And so our goal is to release that first data set to our stakeholder forum with blinded cohort comparisons of their work to blinded cohorts to not only validate it and help us do that, but help them see perhaps some of the things that they may not want to be seen as in terms of their price related to the market. And so we do anticipate that's going to create some market repricing possibly of those that maybe have variations that may not be something that they're going to be comfortable verifying or validating to the public domain. And so we really want that group to help have some time. They're collaborative. They are providing funding to us. We're advocating. We're not trying to point out any villains here, but we are trying to create insight that most organizations just simply have not had in any sort of a meaningful way to really understand that. So that's our first release target as a chance to try to help get validation, get consumer and industry acceptance of this new resource that's going to be available to consumers to use as it relates to how they consume healthcare, and then work that through that third quarter of the year to really be prepared to really release it in a more public way. We also have part of our collaborative brokers, but we also now have a really large contingent of large employers throughout our state that are also very interested in this opportunity of consumerism engagement. And our hope is that by after the September Chance to Cure It, we will release it in a more general way for public consumption and public utilization. And then we'll continue to monitor that, to measure its result, cure it, because we know it's going to have flaws in it that have to be recognized, and try to really assess it through the next calendar year of what we can do to try to really use it to help transform healthcare in a positive way. We do expect employers are going to look at structured benefit designs within networks. If an employer is self-funded, they have more freedom even within a network structures to create different benefit design options related to copay, co-insurance, and already have some employers that are talking about how they're going to respond to this data set as it relates to what they will have patients pay in relation to their care delivery based on the variations of the data set. So we do believe it's going to be transformative. It's uncomfortable, we know, but in all honesty, our stakeholder forum members have accepted that this is the new horizon, and it's important that they be responsive to it and are so far supporting the effort, even though in some cases it's going to be uncomfortable for them. So that's our plan in this next year, with a little longer term strategies behind that we want to introduce to the group here. Thank you.
Wow, Scott, that's exciting. That's really exciting. Very interested to continue to follow your progress. I think when TiC data was made available, when folks like Elizabeth Mitchell were testifying at support, this is exactly the sort of thing that they had in mind. And so kudos to you. All right. Let's move to Katya to talk to us a little bit about how the Policy Commission plans to use this important data source. Yeah, I'm not able to hear you. I don't know if you're speaking.
Oh,
I can hear you now.
Can you see my slides?
I can.
Great.
And just so you know, we're seeing if you have notes, we're going to see your notes also with the way that they are currently displayed.
Oh, I don't think we have notes here, so it should be okay.
All right.
Oh, wait a second. Let me see. Okay, so yes, my name is Katya Fonkych. I am a senior researcher at Massachusetts Health Policy Commission, and Massachusetts Health Policy Commission is an independent state agency, and our core mission, one of our main tasks, are to monitor healthcare cost trends. And of course, prices are a big part of what's driving those healthcare cost trends. So a lot of our analysis and reports are devoted to measuring price variation across providers, price trends, and everything like price related, trying to explain how prices affect healthcare costs and what can be done about that. To analyze prices, currently we mostly rely on Massachusetts all-payer claims database. However, as known, like APCD claims have some drawbacks and challenges for this type of analysis. One known one is that APCDs mostly represent fully insured commercial plans. They don't contain data on self-insured plans, with some exceptions like public plans. Also, like we are using fully processed APCD data, and that takes time. Currently, we are working with 2024 data, and we are at the beginning of 2026. So if we want to look at the most recent price trends, we unfortunately don't have those from just using all-payer claims data set. Another challenge is that of the claims data for measuring prices is that it's not like pure prices. Often prices depend on billing situation, on other codes built along with the main code, whether it was multiple procedures, all sorts of modifiers. So in order to measure price, we need like large sample, and sometimes it makes it difficult to measure prices for a concrete provider or concrete plan and to make those comparisons, especially for rare procedures that could be very pricey, like some specialized surgeries. So in order to solve those, like transparency and coverage of PayerPrice transparency data allows to solve some of those problems. First of all, PayerPrice transparency provides pure prices, the prices that are not dependent on modifiers, that are not outliers, that outlier payments, and that are not confounded by additional procedures on the same claim. They are also measured consistently for each plan provider combination. So if a given payer has certain conventions on how a procedure has to be built, it would probably be followed the same way for like all the payers, so we can comfortably compare prices across multiple providers. Also, transparency and coverage data is monthly. So we have right now first months of 2026 data already available. So we would be able to see the prices that are current for this year. And importantly, payer price transparency includes prices for all the plans, including self-insured plans that we don't have in APCD data. And that allows us to answer the question whether self-insured plans have different prices from full insured plans, and whether we are correct when we are trying to extrapolate costs and prices from our fully insured population in APCD to overall commercial population. That includes, of course, self-insured plans. So as was said today many times, payer price transparency data sets are enormous and they're difficult to work with. So to make it more manageable for our purposes, we decided to test our use cases and in general the validity of this data with a small sample. And that also addresses the issue of ghost codes, because we will be looking at the limited number of providers and the limited number of codes, and we would be able to tell whether or not there is a utilization for those codes present in our claims data set. So we have two steps in our intended analysis. First, we would want to validate the data, and if the data against prices derived from APCD. And the second step would be to see whether we can use it for our intended purposes, which would be primarily comparing self-insured plans with full insured plans and monitoring price trends. To achieve that, HPC found a vendor who was willing to share a small sample of this data for validation purposes. To start, we took prices for the two most common HMO and PPO plans for 2 largest commercial payers in Massachusetts. And we found those plans, and we found who those insurers are, of course, from our claims data set. So we have 4 payer plan combinations for the fully insured data to compare with APCD, but in addition, we also sought to get 4 of similar payer plan combinations for self-insured payers, so that we can start answering our questions about how their pricing can be compared. We also chose like a limited number of providers to start this analysis. We took like most of our larger general acute care hospitals. We took a handful of largest physician organization and got some like lab companies, imaging centers in the mix, just to see how well prices are represented for those types of providers. We took about 200 billing codes, which is not much, but we thought that for the purposes of just comparing and measuring most recent price trends, that could be enough to start. So we looked at, but we tried to take those codes from different service lines in order to see how well they represent, they compare to APCD and how complete they are for different purposes. So we looked at inpatient DRGs, evaluation and management codes, imaging codes, labs, surgeries, administered drugs, and a couple of other categories such as anesthesiology. And we took 3 points in time. We took 2024 data because we want to compare it to the existing data that we have in APCD, which is currently 2024 APCD. We took July 2025 so that we can track change from 2024 to 2025. And currently, even January 2026 is available, so we would be able to see most recent prices. Of course, like we have not received the data. We are currently in the process of talking to our vendor and identifying the issues and just trying to nail down the last specifications. But in this process, we already ran out into some challenges, some of which are related to the fact that there's enormous number of plans for each insurer. And I honestly like wonder how data vendors are dealing with this issue and how other researchers dealing with this, because sometimes it's very hard to tell which plan is which. And although we identified largest PPO and largest HMO plan in our data, in APCD data, it was not easy to find right away which one would be the corresponding plan. And most likely, those like hundreds or sometimes thousands of plans within each payer, they have all the same prices. So what would be extremely helpful is for somebody who has access to all that information to check and group those plans and say, well, these plans, they all are called HMO Blue Cross. They all have exactly the same prices. So that might be helpful. So other challenges related to the fact that sometimes it was hard to cross-check and find the same providers with tax IDs, and we were told that NPI information is incomplete in payer price transparency, so we had to go with tax IDs. Another really surprising finding was that payers, like in Massachusetts, for inpatient payment, APR DRG system is used, which is all payer pricing, not like Medicare MS-DRGs, but like a different one that commercial payers use. And in addition to APR DRG, price is differentiated by the severity level. They're like severity level 1, severity level 2, severity level 3 for every DRG, such as like vaginal delivery. But payers don't provide that information. They just show like one price for vaginal delivery. Although we know for a fact that the price should be different for each severity level. So there is a big question, like, what are they reporting in that field? Probably not the price from a contract, maybe some kind of average across different severity levels, but this is currently unknown. We were told that according to new specifications, they will have to start adding this field and reporting by severity level, but currently it does not provide like really true price. Although it might be enough for the purposes of measuring trends, if their price is like created in a way that doesn't change over time, like simple average of all severity levels. Another issue was that there's like, if we want to measure how prices change over time, we want to take the same plan, but plan IDs change, and there is an issue of identifying which plan would be the same as the one that existed in the previous time period. And then lastly, we found that one of our largest payers, actually the largest payer, Blue Cross, submitted data in 2024 in such a format that wasn't like really machine readable, and the data is missing for that payer. So we won't be able to compare Blue Cross prices, only the other payer that we have. So the way we plan on going with validation, comparing payer price transparency prices with APCD prices, is to derive median price from claims for the same or similar payer plan, and at the largest provider, like take the largest hospital, some really common procedures, look at the median price there and compare that to what this payer plan reported for the same time period for the same provider. Do they align? If they are within like 5% difference from each other, then we can conclude that payer price transparency correctly reflects prices. If not, then we would consider that it failed to reflect prices correctly. So doing that, we would be able to answer the question whether this data set is a reliable source of data, and we can use it for this purpose. And step 2 for us would be to derive most recent price trends for hospitals, largest physician organization, labs, to see whether this data can be used for this purpose. And it will allow us to answer questions like, are price trends the same across the codes within the same service line? Are they the same across different service lines, such as like surgery prices, lab prices? Do the price trends look the same? And if we find that like for different labs, for example, prices increased at the same rate, then maybe we don't even need in the future to have like all complete codes. Maybe just having the handful of codes is enough to tag like price increases over time. So answering these questions will help us and perhaps help others to see how you can use this data even without like major investment. Finally, we would use this data to compare plans for the same codes and same providers across different plans, and compare self-insured prices to full insured prices, HMO prices versus PPO prices, to finally answer the question like, can we really extrapolate our findings from selected fully insured payers that are present in APCD to the entire population? To conclude, I would like to highlight this huge potential of this data if it proves to be comparable and correct relative to APCD, to measure price increases over time, most recent price increases. That concludes my presentation, and I'm looking forward to the discussion.
Excellent. Well, thank you all so much for those incredible presentations. And Katya, I'm sure there were lots of people screenshotting that validation process so they can recreate it at home. I just want to flag that Norm has kindly offered to aggregate all of our questions today, and he will work with the presenters to provide written answers and circulate them to attendees later. So we're going to try to cover as many as we can in 3 minutes, but not to worry. Norm will also save the day and get those questions together and send out answers. So a couple of the questions, folks were kind enough to put answers in the chat, so we won't spend too much time on those. Betty's first question for David: how do you identify ghost rates in order to remove them? David, you did put your methodology in the chat, which we greatly appreciate, but anything else you want to add there?
I would say read the methodology. If you have questions, happy to answer them.
Excellent. And David also put his email in the chat. So if you're looking to reach out to David, it is right there. And then we had another question. I'll go back to this ETL question in a minute, but another question that was answered in the chat. Does the payment represent the allowed amount negotiated or the actual amount paid after deductible copay? And it is in fact the allowed amount. So now I want to go back to this ETL question that we had here from Leiden. What advice can you provide about the hardware, system, software needed to process this data? Do you need a high RAM, a GPU? How many CPU cores, ETL process, and where are you loading it? So Roger and David, I don't know if, or Katya, I don't know if any of you want to take that one.
Yeah, I'd say it depends quite a bit on how much of the data you want to process. We're running everything in the cloud, so it's not necessarily machine specific, but we have several hundreds of relatively large Google instances that are downloading all the files using their download service. And then we have our own ETL pipelines using a combination of on-device processing in addition to BigQuery plus Snowflake is our stack for processing and querying the data.
I'll add that I've done it both in the cloud and locally. If you're doing it locally, RAM is by far the biggest issue. So as much RAM as you possibly can get.
Expensive nowadays.
Yeah, I'll just add that we tried doing it locally and quickly moved to the cloud because it's a little, and we were just doing it for one state. It's a little bit bigger than you give it credit for. All right, let's try to grab one more here while we can. In the early days of TiC, there was a lack of guidance on how to report services that were contracted at % of billed charges. Has that been addressed? Nope. No. Okay, that's a quick answer, so we can grab one more. For Scott, what are the measurements related to member liability that you're planning to calculate? That's a great question.
We've chosen this first year not to get into that because there's such variability there. So what we're just trying to preside right now is the contract rate, knowing that participation obviously is a big part of it. So that's a second round for us. We want to at least get this up and running and then work on that as the next phase.
Thank you. Thank you so much, Scott. I know that we're at time. Thank you, everyone, for your participation today. What an exciting topic and excellent presentations. And please do send Norm any of your questions, and the folks from NAHDO will be in touch with any next steps and follow-up. Have a great afternoon.
Thank you.